Hello. We continue the topic of endocrine diseases in animals. Today we will pay attention to such a disease as hyperaldosteronism. This disease is characterized by excessive secretion of aldosterone, which causes increases in sodium reabsorption and loss of potassium and hydrogen ions. The disease occurs in middle-aged and older cats and dogs. Hyperaldosteronism can be primary or secondary. Primary hyperaldosteronism occurs as a result of an aldosterone-produced adenoma. Adenocortical carcinoma are idiopathic, bilateral, nodular hyperplasia affecting the zona glomerulosa of the adrenal gland, resulting in increased aldosterone production. Secondary hyperaldosteronism is due to a problem elsewhere in the body that causes the adrenal glands to release too much aldosterone. It usually occurs with severe cardiac, hepatic or renal disease. Aldosterone is a steroid hormone produced exclusively in the zona glomerulosa of the adrenal cortex. The principal site of action of aldosterone is the distal nephron, though several other sites of aldosterone-sensitive sodium regulation are noted, including the sweat glands and the gastrointestinal tract. The principal regulators of aldosterone synthesis and secretion are the renin-angiotensin system and the potassium ion concentration. Minor regulators include adrenocorticotropic hormone from the pituitary, atrial natriuretic peptide from the heart, and local adrenal secretion of dopamine. The two major functions of aldosterone are to sustain sodium homeostasis and hence extracellular fluid volume and systemic blood pressure, to regulate potassium homeostasis. Aldosterone is part of a group of linked hormones, which form the renin-angiotensin-aldosterone system. Activation of this system occurs when there is decrease in blood flow to the kidneys following loss of blood volume or a drop in blood pressure, for example due to a hemorrhage. Renin is an enzyme that leads to a series of chemical reactions resulting in the production of angiotensin II, which in turn stimulate aldosterone release. Aldosterone causes an increase in salt and water reabsorption into the bloodstream from the kidney, thereby increasing the blood volume, restoring salt levels and blood pressure. Now you can see the changes in laboratory parameters when the aldosterone level is increased or decreased. Thus, with hyperaldosteronism, increase the retention of sodium ions. As a result, the content of sodium ions in blood serum increases. The excretion of potassium ions increases, causing hypokalemia. And hypertension occurs in animals. In primary hyperaldosteronism, the adrenal glands continue to synthesize an excessive level of aldosterone, despite a decrease in the level of renin and angiotensin. Hypertension is common, so signs of end-organ damage might occur, including hyphema, retinal detachment, hypertensive retinopathy, and blindness. Clinical signs include lethargy, weakness, anorexia, cervical ventriflexion, paresis, ataxia, forelimb stiffness, collapse, polyuria, and polydipsia. The animal loses weight, has diarrhea, dysphagia, and polyphagia. During laboratory research it is found hypokalemia, increased creatine kinase, increased blood urea nitrogen, increased creatinine. Diagnosis has relied on the measurement of aldosterone and renin in plasma. Primary hyperaldosteronism is suspected in dogs and cats with the appropriate clinical signs and findings of hypertension, hypokalemia, an adrenal mass, or enlargement, and increased plasma aldosterone levels. A mass in the area of the adrenals may occasionally be seen on radiographs, but adrenal masses or enlargement are more easily detected with ultrasound or magnetic resonance imaging. Surgery is the treatment of choice for animals with hyperaldosteronism with unilateral adrenal mass and may be chosen for bilateral disease. If a bilateral adrenalectomy is performed, supportive care for permanent glucocorticoid and mineralocorticoid deficiency must be instituted. With complete excision, hypokalemia and hypertension typically resolve. With bilateral disease or in the presence of metastasis, medical management may be indicated. Hypokalemia can be treated with oral potassium gluconate, but potassium losses can be severe and difficult to normalize with oral supplementation. Intravenous potassium chloride is more effective than oral therapy. Spironolactone is an aldosterone antagonist that decreases sodium and water absorption as well as potassium losses. Clinical signs of hypokalemia often improve even if potassium levels remain below normal. Most of these animals are hypertensive, so treatment with calcium channel blockers and angiotensin-converting enzyme inhibitors such as benazepril, captopril, enalapril, fasinapril, lisinopril is common. Thank you for attention.